Colleagues, it's my great privilege to welcome on behalf of the Center for Health Professions Education and also the Faculty of Medicine and Health Sciences, Dr. Jason Frank, who actually I think needs very little introduction. I don't think there's anyone in the audience who haven't heard the name Jason Frank before. But let me do it in the proper way and introduce Jason properly. Jason is a clinician educator with a focus on all aspects of health profession training systems. He currently holds roles of the Director, Specialty Education, Strategy and Standards in the Office of Specialty Education at the Royal College of Physicians and Surgeons of Canada. And he's also the Director of Educational Research and Development in the Department of Emergency Medicine, University of Ottawa. And I can now understand why some of our emergency medicine colleagues are here. He's cross-appointed to the Faculty of Education, University of Ottawa, and the Department of Graduate Studies, Ontario Institute for Sciences for Studies in Education. He obtained his MD from the University of Ottawa, Faculty of Medicine, and his FRCPC in Emergency Medicine at the University of Toronto. He has a Master's of Education from the Ontario Institute for Studies in Education. He has published and presented widely in medical education, where his research interests include competency-based education, faculty development, program evaluation, and curriculum development. He is known for his work with the Royal College of Physicians and Surgeons on the CanMEDS projects since 1994 and as an award-winning teacher. Dr. Frank was the recipient of the 2013 Council Award honoring outstanding physicians presented by the College of Physicians and Surgeons of Ontario to recognize physicians whose performance and expertise in their career has been exemplary. He was a 2005 Emergency Medicine Teacher of the Year in Canada, an honor awarded by the Canadian Association for Emergency Physicians, and also the 2007 Meredith Marks New Educator Award winner from the Canadian Association for Medical Education. He was also a finalist for Canada's Globe and Mail Top 40 Under 40 in 2011. Dr. Frank lives in Ottawa, Canada with his wife Ruth, who's also a physician, and they have 4 sons. Jason is going to talk to us this afternoon, and the topic of his talk is a health professional is more than a clinical expert, the CanMEDS competency-based model of specialty training. Jason, welcome again. We're looking forward to your talk, and we want to thank you that you are willing to spend such an amount of time with us at this faculty. We really appreciate it.
Good afternoon, everyone. Thank you so much for that kind introduction. You are wonderful hosts. I've really enjoyed my time here, and it motivates me to travel around the world and speak to groups. I learned so much out of the dialogue between us. So just before I begin, can I just ask, I want to get to know who's in the audience, because I'll tailor my talk to you. So how many of you are physicians? Put your hands up. Okay. How many of you are physicians in training? Because I saw some hands go halfway, I kind of am a physician. Okay. How many of you would be affiliated with, say, nursing? A few. Occupational therapy? Physical therapy? Speech and language? Another discipline I haven't thought of in the health professions? Okay, what about organizational psych? Okay. What did I miss? What were the other disciplines? Public health, okay. Okay, dietetics? Clinical psych, okay. So what a diverse group we have. Did I miss another one? Surgery, okay, all right. You want to be with the physicians. Okay. In Canada, we group them together. I apologize. So you'll have to help me if I say a Canadianism, which I am bound to do. My accent is already readily visible. If I say something that doesn't make sense, you just have to yell moose or something, and I'll adjust. So once again, I was asked to speak about thinking about health professions training beyond clinical expertise, which is a revolution that's been happening in a number of places around the world, has really changed the way we train health professionals in Canada. And I look forward to having a discussion with you today. I have a few slides just to set up our conversation, and then I'd really love to have a conversation with you about what you hear. Just by way of introduction, you already heard I'm an emergency physician. I still do clinical work. It's very important to me. It just means I sleep less. But that prepares me for jet lag when I fly places like this. As a educator, I work as a consultant to groups, and my primary job is at the Royal College in Canada, which is a body that oversees training standards, accreditation, certification exams, lifelong learning standards for all groups of physicians except for family medicine, which is in another college as a quirk of history in Canada. I'm a student of competency-based approaches, and I've been thinking about this for 20 years. And you may think I'm a slow learner, but it's a very complicated topic, and only lately have we moved to implement those ideas. How many of you have heard that term, competency-based education? Does that mean anything to you? A few of you. Some of you are kind of tentative. You're putting your hand up halfway. Okay. Those of you who've heard of it, do you feel comfortable enough to talk to your colleagues about it? Put your hands up if you could maybe give a grand rounds on it. Okay, you're very humble. It was 4 of you put up your hand. How many of you have heard of CanMeds? All of you, okay. In your kind introduction, you said that my name has been heard before, but if you Google my name, you get an actor who played a Mighty Morphin Power Ranger. And I think that person's far more important. Can I just ask by a show of hands, how many of you in this room as health professionals or other professionals feel like you're incompetent? Just asking. Some of you put up your hands. It's the first place in the world that anybody has put up their hands. Usually I ask that question. So how many of you feel like your education perhaps didn't prepare you for the stage you're at right now? A few more. You're a very humble group. Most places I go, I get a tentative look when I ask that question, and very few people actually put up their hands. They're kind of wondering what I'm going to talk about. Maybe I'll tell you a bit of a story as to how we came to have this conversation. I dial back to 1990. And in 1990 in Canada, there was a number of forces at work that were restructuring healthcare and the perspectives of the health professions. It was a financial crisis with respect to healthcare. That continues to grumble along, but it really hit home around 1990 in Canada, where governments felt like they couldn't afford the healthcare system. And in particular, they were no longer interested in giving health professionals any more money. So they started to reel in the pay that they would offer. In addition, there was actually a doctor strike in Canada, and that was pretty unprecedented. That's never happened in the health professions before, and it really divided the medical profession as to whether or not the medical profession should ever strike and not serve its patients first. The college I currently work with, the Royal College, started to receive letters spontaneously from its membership. We have about 50,000 members in countries around the world. Most of them are in Canada. And the kinds of letters were different than the usual, because usually the letters along the lines of, please help me get my maintenance of competence points, why are you charging me so much for my dues renewals? Instead, the letters changed to a quality that were along the lines of, I'm concerned that we're not preparing the next generation to work in this environment. Something's changed. And so the kind of comments we would get would be something like this. This is kind of a paraphrasing of a few of those letters. I trained for years under supervision. I can operate almost with my eyes closed. I'm that good at medical expert. But I didn't learn how to run a practice. The hardest lessons I learned were after training. Another example of these kinds of letters would be, I'm here in practice, I know my discipline cold, and yet somebody else, a manager in the healthcare system, a non-health professional, is allocating resources in a way that I disagree with. I have no idea how to influence that person. So there was dozens of these letters. They came in spontaneously to the point where it was a bit of a wave of influence within the building. And for the first time, our college paused and decided that perhaps we should re-examine the model we use for training. I'm not sure if some kind of similar dialogue has happened in this country, but it seems to have around the world. So in this session, I'm going to tell you about the response, which was called the CanMEDS project. And I'll tell you a little bit about our thinking that helped us move beyond clinical expert. And then I'll finish with a little bit of the impact of the work so far and what we're working on right now. At the end, I'd love to hear your comments. If there's something that you disagree with, I'd love to hear why. If there's something that makes you mad, I'd love to hear that. If there's something you think is really useful, I'd really love to hear you say that as well. So let's have a good discussion at the end. By the way, this is the CanMEDS diagram. Initially, when CanMEDS was rolled out, it was actually a list of 7 domains. Do you know why we rolled it into this picture? Anybody have an idea? Instead of a list? Easier to remember? Yeah. It was still just 7 things. I mean, our brain's supposed to remember 7 things. Anybody else? Okay, they're all equally important. So it actually addressed a few things. So we started getting hate mail that said, yesterday I was a medical expert, now you're telling me I'm 1/7 a medical expert? Is that what my college is doing to me? And this diagram is to represent the fact that it's a construct and they're actually overlapping domains of competence. We grouped them into 7 buckets for our rationale, but we wanted to demonstrate to our population that we were serving that really medical expert was at the core. This diagram and the CanMEDS framework, as you'll hear later, has actually been adopted by 13 professions that we're aware of and 1 engineering school. And they just swap out medical expert for whatever they're dealing with. But I digress. So this project started in earnest around 1990 and with a task force that really started to re-examine the way we did clinical training in Canada. And I just want to share with you some of the threads that emerged out of that examination. We started to do a literature search and start to speak to experts in medical education, asking them questions we didn't ask them before. And this kind of paper emerged. This is a classic paper. It's quite old now. It's 20 years old. It came from the Journal of American Medical Association. And what Christakis did is they took all of the world's gray literature, mostly from the US, and looked at, for a thematic analysis, all of these reports on how to reform health professions education, what were they recommending, and has anything changed? And what Christakis produced was 100 years of reports in the US asking for the exact same thing to change that hadn't yet. And it was improving communication skills, having health professionals prepare to work in a team, have them have an illness perspective, not a disease perspective, biopsychosocial spiritual model. All of those things are recurring through 100 years of publication. It's kind of an indictment of educators like us if we hadn't responded to that at that time. This kind of phenomenon was in the literature. It says that at each stage of training, graduates arrive with lacunes, with gaps in their espoused competence. So if you look at every medical school in North America, they'll have a list of objectives of things their graduates are supposed to have learned. And every year, those trainees move on to the next stage, postgraduate education. And every year, those interns feel unprepared for the work that's handed to them. My training was, welcome, today's your first day of postgraduate training. Jason Frank, here's your call schedule, you're on call today. And here's the call pager, and here is the code pager. If somebody's dying, they'll call you. I felt tachycardic. I needed defibrillation at that point. I was unprepared. Every year in the emergency in July, I'll get a new crop of interns, and every year in July, one of those interns will present a case to me, and they will sheepishly say, but Dr. Frank, I've never done one of those. I've never seen one of those. And often it's something that all of us would agree would be a core content. An example would be basic suturing, a lumbar puncture, things that would be espoused in a Canadian medical program. And you can extrapolate this to any health profession. And when I ask, why don't you know how to suture? Your med school says that you're supposed to be able to. They said, well, the surgeons told me I was going into psychiatry, I didn't need to. So they just took the needle driver away. So that's the ad hoc model of medical education. The phases of medical education, and again, insert any health profession, we have these silos between them, and they're a very big gulf that we ask our trainees to leap over. And sometimes they fall. And sometimes they arrive and they have that tachycardia I have with the pager, and they feel unprepared for their work. And the latest issue with this is, not only are they unprepared for their work, there's increasing evidence that maybe, just maybe, we're causing harm to our patients. The quality of care is lesser when these people are unsupervised or inadequately supervised. Another theme is this. Maybe you've met this person. They're a student in difficulty. This is Sonia, and she's well known. She has a reputation already in her training as being a difficult learner. She passes exams in spades. She does very well on exams, but nobody wants to work with her. Supervisors don't like her. The nurses don't like her. Her colleagues don't like her. And so people propose that maybe she should actually fail. But there's little data on which to make that basis. And frankly, the faculty think that's really a lot of work. There's going to be committees if they fail her. So they just pass her. Maybe someone else can get her at the exam. So that's called failure to fail, and it's a pervasive phenomenon worldwide. And it's something we can do better. Right, you're wincing at my diagram. This is one that outside of the health professions that I find stakeholders are very concerned about. So increasingly around the world, governments, patients groups are looking in on the health professions, and there's a number of concerns they have. But the one they often talk to me about is, why is our program time-based? Meaning that we say that it takes 5 years to get through this training. And the way we organize it is we say you have to do 2 months of this and 3 months of that and 4 weeks of this. And if you pass that, and we know there's a failure to fail phenomenon, we assume you've learned what was supposed to be learned, and off you go. And if you pass our exam, then we give you certification. That's a time-based system, and it's the nickname for it is the teabag model, where we take a trainee, we steep them for a bit, and off they go. They're a healthcare professional. Increasingly, the question is, what evidence do you have that this person has all the competencies that you espouse? We looked at complaints about the health professions in Canada, and there's this theme almost once a week in Canada in the big newspapers. There'll be some very provocative article that says that so-and-so doctor or so-and-so nurse has made this egregious error, and it reflects badly on the whole profession. And often it's really an outlandish scenario, but these are real cases. And sometimes it actually is a systemic error in the way we've designed our training. An example is there was a coroner's inquest in the province of British Columbia in Canada recently, where 3 radiologists who were senior practitioners systematically made errors for a decade. And as a result, people died. They missed cancers, they misdiagnosed things. And in the inquest, what they realized was these people trained a while ago, and ultrasound was really hot at the time they graduated. And subsequently, they worked in small communities where they bought a CAT scanner, a CT scanner. And those people acquired that ability by just doing it. So they asked the Royal College, what is it about your system that says that this person can learn and practice by just doing it? And as a result, over a decade of reading CT scans wrong, people died. And so that's changing legislation. It makes governments tighten the noose around professions and take away our autonomy. Some more bad news when we looked at this. I'm kind of giving you a case here for why we needed to change. This is Chowdhury's systematic review. It's from, I think it's from Annals of Internal Medicine. And they looked at the world's literature for any paper that addressed how people's competence changes over time when they graduate from health professions. They focused on doctors, and their gold standard was a variety of things. So they looked at how up-to-date you are with, say, medications for a certain problem. And they put together all of those scores from a variety of papers, and what they discovered was this pattern, that we have a ballistic model of medical education, that people are most up-to-date, in general, in their studies, very early after graduation from a registrar training program. That's when they're most evidence-based. And over time, we tend to become a little bit more discompetent, and over time, and the pattern in the studies was, you just hope that they retire before they hit re-entry. There were a few ameliorating things. It helps if you are female, working in a group practice, working in some academic setting where you taught and supervised anybody, because they'll ask you questions that you have to look things up. All of those things prevented you from having this scenario. So short of a gender change, reading and teaching is a good thing. We decided that something had changed in the environment as well. We lived in an age of accountability, and people were asking questions of the professions in an unprecedented way. At about this time in the UK, some of you may have been there, was the time when the Royal Colleges in the United Kingdom actually lost some of their power to certify. It was given to a body of lawyers called the PMET-B, briefly. And that had to do with the government's lack of confidence in the Royal College system for a little while. The fact that they gave it to lawyers was another sting, but that's another story. We turned to an approach called competency-based, and we thought that was actually a better way to train health professionals. And for us, it's been an evolution for the last 2 decades, and it's led to a conversation that's happened around the world. So maybe I'll just give you a quick intro to competency-based, so we're all on the same page. But I'll do that relatively briefly so I can really tell you more about the CanMed story. Competency-based education, when we did a systematic literature review, had 500 definitions. It's new, relatively new to the health professions, but other professions have been doing it for years. There's an article from 1950 for American teacher education. It's a focus on outcomes. And this approach, and it's just an approach, says that outcomes are king. How you get there can actually vary tremendously. And that's quite different from traditional health professions training, which has a lot of prescription around the process. You must do 4 weeks of this. You must have a binder of objectives. Competency-based says what I really care about is show me the proof that your graduate can do this and prepare them for the next stage of their career. It uses competencies, and a competency is just an ability. It's something you can observe, but it's applied knowledge, skills, and attitudes. So an ability is a different way of organizing things. And this reflects some current thinking of the psychology literature, expertise literature that says just the way our human brain works, it comes in a spectrum of ability for every given domain. Whether it's playing music or cricket or medicine or nursing, we tend to start in some sort of novice zone and move towards some sort of mastery zone. You can actually make statements about each of those steps along the way, and you can use that to organize training. So this is a little different than having a curriculum which is heavily weighted to a bunch of knowledge objectives. You should know this, know that again. Instead, this is demonstrate that you can do. Show me, apply to a patient scenario, that sort of thing. Being competent changes because now it says, instead of being competent, the traditional definition was, once you're certified as a health professional, you're competent for life. Oh, we may make you participate in some maintenance of competence thing, but really, you're competent. Now the definition is, you should be able to demonstrate how you possess the required abilities for a given context. You must define the context. Working here in this building is very different than working in a very rural place without the resources and the team and the technology. So you have to define the target. Competency-based education begins with the end in mind. It says, what are the abilities needed of graduates? And so that led to the CanMEDS project, Reframing Training. We said, what are the abilities needed of every physician in Canada? We started with medicine. And we commissioned this project. The CanMEDS framework was the product. And really, it's just a way of describing a contemporary approach to the abilities needed for effective practice. And I need to remind you that CanMEDS is very generic. We require every health professional group to adapt it to their reality. So the CanMEDS framework on our website actually looks a little bit different for psychiatry, surgery, and our 81 other disciplines we have in Canada. Similarly, it looks different when you look at the nursing version of this and the physio and the OT version because they're different professions. It's a place to start from. It's truly a framework. This is how we went about it. We commissioned expert panels from a variety of perspectives. We did that systematic literature review looking at all these aspects of medicine, all that evidence about the things that people have asked the health professions to do. We even had an epidemiology report looking at how the burden of illness has evolved in Canada over time. And one of the things we realized was we needed to emphasize chronic illness over acute, whereas it's been almost all acute training before. We need to emphasize ambulatory training over a hospital-based. That was a real evolution to meet the needs of the population. We did a lot of consultation across all stakeholders, all health professions. We did it in an iterative way. And then the draft framework was actually sent out to 2,000 recently graduated physicians, and the question to them was, for the following list of competencies, is this really relevant to your practice, and how well prepared were you for practice? And we were able to calculate the gaps between those two. By the way, do you know what the biggest gap was in terms of what domain of CanMEDS? People said in practice their biggest gap for preparation and importance, you know what it was? Have a manager here, medical expert? Which one? Advocacy. Their actually biggest gap was manager in 1995. And their rationale that they put in the comments was like the first guy who said, look, I can operate with my eyes closed. I have no idea how to set up an office. It took me 6 months to figure out how to get paid, and so on and so on. So our training really lacked our preparation to fit into a healthcare system. So that produced the first version of the framework, which was around 1996. I want to make a special mention because as far as I know, CanMEDS is the only framework in the world that did this. It asked the public what they thought a good doctor was. And there's been some studies that have asked a version of that question, But we actually conducted a whole series of focus groups, hundreds of thousands of dollars worth of activity, and asked people, what does it really mean to be a good doctor? And that's a very careful question, because if you ask the public, they're just going to say yes to everything. I want more, better, yes. But the focus groups were constructed in a way to actually tease out what those elements were. And it's very powerful to come back to a medical school or other institution and say, the public wants us to use our influence to make healthcare better. That became Health Advocate. It's very different than saying, well, we got together in a committee this weekend, here's our report, we think you should teach Health Advocate. That tends to be filed a little bit deeper in the pile than saying the public wants us to do this. And that became a powerful rallying cry. We're actually in our 5th phase now of CanMeds. The initial phase was all developing the framework. We had a little pilot phase where we started to tinker with the system. We made it a mandatory component of all the Canadian medical training programs in about 2001. So we gave a few years to phase in the topic, but now every program is accredited based on CanMeds. So you can imagine I'll send surveyors to 1,000 different cities, 1,000 different programs and cities, and at some point we ask the faculty to leave the room and the trainees are left in the room, and we say, so how do you really learn Health Advocate? How are you assessed on professionalism? And if they give kind of a blank stare, that's recorded on the accreditation. It becomes a weakness. Similarly, every trainee in our system is required to have demonstrated their base ability in every one of these domains. So early on, I was mentioning earlier this morning, we got letters saying, do you mean that you would prevent the world's best technical surgeon from progressing to be certified if they didn't have good communication skills? And I wrote back and said, yes, because that's what the public wants. Everybody has to meet a minimum standard in every domain as defined by their own peers. So that became the new CanMed standard. After 2002, we went into a faculty development phase, and now we're in a new phase where we're revising the framework. I'll tell you about that in a second. So here's our domains. I thought I'd just mention a couple of things about the CanMeds framework, and I'd love to hear your comments later on. We divided it into 7 domains because that was the sort of thematic analysis that came out of all of that endeavor. It turns out that there's been a number of research studies on CanMeds, one of which did a factor analysis on a large 360 or multi-source feedback instrument, and it actually factor loaded to 7 domains, so that may be teleologic, but it seems to have worked. Medical expert is the core, and we listed some of these other domains that we actually call the intrinsic roles. We used the roles concept as a way of communicating to a lot of different people that physicians need to make explicit all of these abilities because all of them contribute to competence. That's what the literature and the other studies told us. For example, we asked the medical legal insurers of Canada, give us some information. We realized that they couldn't tell us details because that'll bite them in court, but we asked them to give us a bit of a needs assessment about the physician problems that they see in insuring and defending physicians from lawsuits. Their number one issue was, of course, what would you say? Communication skills, absolutely, absolutely. With a few stereotypes that seem to bear out for a few disciplines. After CanMeds was launched, their communications lawsuits decreased over time. And we can't take credit for it, but it's certainly an association. When we came around and revised the framework in 2005, we asked them the same question again, and they said, we're really concerned about professionalism issues, and also we're very concerned about physician wellness, because physicians are burning out with their workload. Many of them are using medications to try and stay awake, stay calm, deal with their anxiety, whatever it is, and as a result, it's leading to patient harm and lawsuits. So they really wanted us to expand on our concept of physician wellness as an example. We were once asked if the CanMeds framework was, how it was oriented. What's the relationship between medical expert and the others? And we're trying to be consistent about our language. We say these other domains are intrinsic to being a medical expert. To be a doctor requires all these domains. So a medical expert's kind of the core concept. It's what distinguishes us from other professions. You know you're not a pilot because you're a medical expert. You have health professions, clinical competence. And the kinds of competencies that we group there in the current framework are things that we would all recognize: history, physical, clinical decision-making, therapeutics, procedures, and so on. The communications domain, we wrote it so that it exclusively focused on the clinical encounter, a doctor and a patient or a patient and family, and other communication skills are woven through the whole framework. We did that because in the first iteration, a number of other communication skills were there, like presenting research, giving talks like this. And some residency programs, when we tried to accredit them, they said, of course we teach communication skills. We give research talks. And that wasn't good enough. So we wrote it, so we said every physician and surgeon in our system must have communication skills training that is appropriate to their discipline. For psychiatry, that's enormous emphasis. For surgery, that may have less emphasis, but it's still essential. And if you look at the world's literature, it says that the better communicator you are, the better your patient-level outcome. That patient-level outcome could include satisfaction, likelihood to sue you if something went wrong, but it also includes things like being adherent to therapy. There's an excellent study that looks at cardiologists judged by their gold standard on how effective their communication skills were and the mortality of their patients with congestive heart failure. We know that congestive heart failure patients live longer if they stay on their therapy. We know they stay on their therapy, the better the cardiologist's communication skills are. That's a hard outcome for a so-called soft topic. So this is really framed around, we picked one of the communication skills frameworks. The ones we chose was called the Calgary-Cambridge framework, some of you may have heard of. And it's just a nice way of organizing a clinical encounter and the things you would expect. I'm not sure when the last time was that you've listened to a trainee that you respected in their communication skills. We did a little experiment in my own home department. We listened outside the curtain to our senior registrars who were considered excellent in their fields and ready for practice almost. And we listened in horror as they didn't introduce themselves, didn't establish rapport, went straight to a closed question. And we thought, what have we done? You know, how did they forget everything we gave them? The collaborator domain reflected a body of literature that said that the era of the lone practitioner is over in North America, that almost every health professional works in a team. And a team is not just a group of people with a shared purpose, because you could say that's what a group of people at a bus stop are. That's not a team. A team is a group of people who have interdependence and different expertise and have shared decision making. And that takes a special set of skills, which my generation was never introduced to. And we all know our colleagues who have a variety of levels with this. There are times when I follow into the emerge department, I can almost tell who's on as the attending physician because the nurses are really upset. And I know that person has trouble working with other health professionals. There are other people who I admire for their skill and their ability to bring out the best of everybody in the room. So the collaborator role includes ability to function in a team and the ability to manage conflict, which is just inherent in healthcare. We're limited resources, lots of people who believe that they're expert in every problem. So you need to have skills in order to help with that decision making. The manager role is the second most controversial, and it includes everything a physician needs to function in a healthcare system. By the way, I'm talking about physicians. You can insert any health professional. So that includes understanding how healthcare works, understanding how you get paid, understanding how to be effective in practice, managing your own career. All of that was grouped under manager. This domain is proposed to be radically reworked in our next version. Health advocate is the single most controversial domain. When the US ACGME organization came to Canada and talked to us about our CanMeds project in 95, 96, they picked up a lot of that material and brought it back to the US. They dropped health advocate when they made the ACGME competencies for a variety of reasons. Health advocate was the one that came from the public focus groups, and it came from a dialogue, something like, you as physicians have a privileged role in our society. You have power and you have knowledge and expertise. I need you to use that for my own benefit, for my family's benefit, but I need you to use it for our population's benefit. You have a unique opportunity to lever the system, make it better. So we said that every Canadian physician had to have some core health advocate expertise. And it varies tremendously by discipline. If you're in orthopedic surgery, the objective might be something like, we expect to recognize that the little lady whose hip you're fixing actually had falls. And why did she have falls? Is it her living scenario? Does she need a referral to a social worker? Does she need osteoporosis meds? So you're recognizing the determinants of health in that patient may lead to a referral. It was never part of the curriculum for orthopedic surgery before. Now it's on the exam. If you're a community medicine physician, well, this is bread and butter and it's the majority of your training. The concept of physician as scholar came from a number of sources and actually includes 4 big things. It says basically we are a health profession that's dedicated to science and advancing thought. So it says you must be a lifelong learner, and we're serious about that, so we ask for people to demonstrate their skills. You must be able to critically appraise literature. Most programs around the world would shrug to that. Of course they do that. They have to teach others. We call that facilitating learning. And they have to contribute to research. So that doesn't mean everybody's going to be a researcher. In fact, the minority of people will go on to be a clinical scientist. But everybody probably enrolls a patient or at least consumes research over the course of their career. So we made that a requirement of all Canadian physicians. And finally, we defined the last domain as professional because we framed it around one's obligation to be part of a profession. So that includes professionalism, but it also includes obligations to give back to the profession, meaning I'll be a peer reviewer and I'll keep up with the medical legal standards in my discipline. And it also included a commitment for sustainable practice, which was our way of framing physician wellness. We said it was actually a competence domain that could be taught, could be learned, it could be demonstrated. For my emergency medicine residency program, registrar program, we talk in our academic program about the impact of shift work on health, because it's the single biggest predictor of physician burnout in my discipline, sustainable practice, and so on. If I burn out, I'm not serving society anymore. I can't see patients. So it's part of our components of physician wellness. That was your whirlwind tour of CanMeds, and I'd love to hear your comments about it in a minute. So this little project that we began as a answer to some forces that were at work in Canada has legs of its own. It's actually taken off. To the best of our knowledge in our CanMeds office, there are 30 jurisdictions around the world that use it as a framework in some way, shape, or form. So if you're a medical student in Denmark and now in South Africa, Belgium, the Netherlands, parts of the UK, all of Australia, your curriculum in some way, shape, or form is based on the CanMeds framework. And that's not because there was some marketing guy with a briefcase handing out flyers. It's because it was answering a problem that was an off-the-shelf place to start. And for us as Canadians, we're not making money off this. We want to work with you to make our collective framework better. And all of us learn from all this dialogue. It's had this impact in Canada in that it's revolutionized the way we train, and CanMeds becomes an everyday conversation. It's just considered part of the room. It's present. CanMeds is a way of thinking about medicine and other health professions. It hasn't been easy though. It actually took us 20 years. Not every phase of our implementation was achieved its objectives. And we realized over time that the Royal College needed to really be involved in faculty development. Just writing standards and saying thou shalt was actually a way to fail. We needed to actually be quite sophisticated at supporting all of the medical schools in the country, and then eventually other institutions around the world that were adopting, bringing workshops, bringing materials, publishing books. We didn't have a publishing arm when we started this. Capturing the best innovations we could find and putting them on websites and so on. That became part of our everyday business as well. We also began to support a subspecies within the health professions that was just nascent when I started, and that's people like me, clinician educators. 1 foot in the education camp with training, 1 foot in the clinical world. We need those people to actually make the translation between these concepts and frontline. One of the reasons, it's just one, but one of the reasons why I'm still involved in my clinical practice is I can stand in front of a group of my peers and say, I did this, so you can too. It's not just an egghead concept from the ivory tower. And I think that's a really useful message to bring to my work. So what's next? We're moving on to a new version of CanMeds. We're very excited about it. Some of the people in this room have actually contributed to it. They're on our International Advisory Committee. So Stephanos is one of the people that's recently contributed to the shaping of this framework. We're taking CanMeds 2005, our current version, and we're going to roll out CanMeds 2015. You're welcome to download the second draft, which was released a number of weeks ago. It's on the Royal College website, and I'll gladly share it with you. You'll see that we're kind of changing the diagram a little bit, moving away from the metaphor of a flower towards more of a compass. Ongoing emphasis on all the domains. There's a proposal to change the manager domain to leader, to emphasize leadership skills, again, to shape healthcare. There are a number of other changes within the framework that I hope that you'd be interested in commenting on. The biggest change that we propose to roll out is to have a series of so-called educational milestones come with CanMeds. So in the next version of CanMeds, there'll be education statements, competency statements for each and every CanMeds competency from the first day of med school to the last day of practice. A golden thread for the Canadian medical community to use as their palette as they construct curricula. Our thinking and our hope and our aspiration is, imagine a day where on your first day of health professions training, welcome, here's your e-portfolio, log in, see your CanMeds-based milestones. Your first day of being, after your health professions core degree and you move on to postgraduate, it says, welcome, I see you're a postgraduate registrar now. Let's use your e-portfolio with this new interface, and it's tailored to your discipline. When you get certified, it says, welcome, I see you're now a certified practitioner. Please use this interface, same piece of software, but now I'll guide you for your lifelong learning for the rest of your life. All based on these milestones that stretch from the beginning of the training to the end of practice. That's our aspiration, just a little project. We're 3 years in. Our official launch will be in Vancouver, Canada at the International Conference on Residency Education in 2015. And I hope that some of you will be there. We'd love to share that event with you. We'll have a discussion about implementing all of these grand ideas. We've written the first draft of the milestones. For medicine, from the first day of medical school to the last day of practice, the raw draft was 1,100 milestones, which we edited out redundancies and got down to 800. So that's 800 statements that need to be woven into curricula. On the other hand, if you think that that training period or that practice period is probably 30 years, maybe that works out okay. We calculated in our current registrar training programs, there's about 400 different assessments that happen in our current system. So we actually think that it's just switching out a different way of doing the same activity, we hope. So I want to finish with a thought. Is this really worth all this effort? I mean, it certainly keeps myself and other people employed to write all of these documents and do all this research, but does it really make a difference? And there's a number of lines of evidence that give us some information about that. I want to introduce to you just this one author that I'm really thinking about lately, and I mentioned this yesterday to the group. This is a guy named David Ash. You may be familiar with him. I think he's actually from Pennsylvania, maybe. And he's a health services researcher, and he has a series of papers which have shaken me to my boots. He has access to a database of American obstetricians, and he's looked at a number of competency outcomes. So he's looked at, for example, a number of really objective measures of their quality of dealing with labor and delivery, like length of stay, mortality, infection rate, REOR rate, really concrete things, mortality for a mother and baby. And when he puts that together as a measure of a marker of somebody's competence, he finds some really big things. The first thing he finds is he can actually group the American obstetricians in his database, thousands and thousands of data points, into quintiles, so that there's a big difference between the top group and the bottom group, and it's a 3% absolute difference. The other thing that's important is that difference is predicted by where they trained, and it's the complication rate of their program, of the group where they trained, and it predicts it on into their career. We truly have a ballistic model in Ash's papers. It says over time, the good news is everybody gets better. For every decade in practice, you drop your absolute complication rate by a percentage. That's good. The bad news is for whatever quintile you started in, you'll never catch the person above you. So that says our work is really important because how we train people predicts their future practice and their impact on patients. So in my mind, this is all worth it. So in this session, we talked about the CanMeds project and how we broke out of the mold of emphasizing medical expert and on into what we call the intrinsic roles, which we think are important for practice. It's had an impact around the world that we didn't anticipate, and we're always moving on to try and make our programs better. We think this competency-based approach is actually a better way of training, and it's because our patients are worth it. Thanks for inviting me. Happy to take any questions you have. I'd love to hear your comments. Go ahead.
So a conversation, I'm with emergency medicine, and
Welcome,
a
brother.
conversation that we often have with our residents when we try to introduce things like this. We certainly had quite a battle introducing some scholarship competency a while back, and we're looking at introducing stuff around management. These burnt out tired registrars come to you, residents come to you and say, our lives are already so full. How can you justify putting more things in? How do you answer people when they say that?
Yeah, I think that's a legitimate concern. And so when we did this, we didn't take anything out of medical expert, but we definitely had hard conversations about what's an essential competency for practice. And if it couldn't be connected to practice, it didn't belong. If it did belong, there had to be room in their world to make it effective. So an example is my emergency medicine program requires every trainee to do a research project, every single one. They have to present it at a research day in their 3rd year, so they have 3 years to pull it off. They have a little bit of time if it doesn't work out, because things happen. But in order for that to be efficient and possible, we had to make sure that there were methodological people around to give them coaching, and there had to be a research coordinator that would, help them facilitate the system, get ethics and so on. That has worked across Canada from coast to coast. We've managed to carve that out. But it's part of our commitment to the education. If we're not committed to it, then we didn't put our money where our mouth is, and it didn't belong in the curriculum. Who's next? Please.
Thanks very much. That was a very interesting talk. I just had 2 quick questions for you. One is around assessment, or how does one measure some of these competencies? Because it seems like some might be more easy to measure than
Sure.
others. And how much agreement do we have around what constitutes that competency? So if we measure something, can we consistently measure it?
Yeah.
Or is it affected by the context?
So the answer is an enormous PhD thesis on assessment, but I'll try and distill it down. The first thing I'll say is, if you value something, it should be assessed. It sends a signal through the system. The second thing I would say is a piece of good news. The good news is the literature is filled with assessment instruments. Some of them are better validated than others, but there's actually dozens and dozens and dozens of instruments that are available in the literature. They're not all in one place, and that's actually a problem for our design. We need them all in one place to choose from. So we're going to make a new library of these assessment instruments. Another piece of bad news is that the world's literature says that for workplace-based assessment, the reliability is very low. That for all of us, if we look at somebody working, we all tend to have a slightly different opinion. Not a radically different opinion, but slightly enough to be significant, I would say. And that can be ameliorated. It can be ameliorated with faculty development and training, better instruments, and asking the assessor different questions. So one of the latest lines of evidence is, if you ask an assessor, mark this person from a scale of 1 to 10, no anchors, it's going to be all over the place. If you ask the assessor, can you tell us whether or not this person meets expectations? Well, their expectations are going to be based on their own mental model, and we all vary a little bit. If you ask them, can you entrust them to do this task, and define entrustment as, could you leave the room and they would be safe and effective? All of a sudden the reliability improves. It seems like we all have a shared concept around that as clinicians. So there's no question that you need to define these competencies in a way that everybody would endorse. And we have a process for that in Canada with these consensus committees for that, for each discipline. You need to select an instrument which is practical, useful, and you need to ask the right question of assessors. Even then, we know that that's still problematic with workplace-based assessment. So the way around it is to choose a kind of a pixelated model. No one assessment counts for an enormous amount in our system. Instead, hundreds of small assessments count a lot in our system. And that's something we're continue to roll out. Having said all that, objective things like certification exams, we still have a role for them in our system. My European colleagues really laugh at us when we put so much emphasis on certification exams. We still think there's a role. Other jurisdictions do not. Hope I started to answer your question. Go ahead.
Thank you very much for an insightful talk. I just have a question of clarification. So we involved, and I know we involved with various levels of teaching from the undergraduate and then the postgraduate level training.
Yeah.
So in terms of what you've outlined to us, is it the postgraduate level training, so meaning graduates who's already graduated as a medical doctor that then goes into specialist training? Or is the same model being applied also at undergraduate level, where
It's
you
the
study
whole
for your first
continuum.
degree, and how does it differ for undergraduate versus graduate medical programs? So just the various aspects.
In Canada, you could consider sort of 3 or 4 phases of training. There's the undergraduate and postgraduate, Most people do a little bit of postgraduate and then continuing professional development. All of those in Canada use CanMeds, all of them. So that provides us an opportunity to try and deploy these milestones that if we can get everybody to agree on them, we can actually use the same set of milestones from the beginning to the end. Currently, every medical school makes their own unique take on a curriculum. It's quite tailored to the local site for the MD, for the undergraduate program. The postgraduate programs are set by my office, so it's a national level set of standards. CPD is kind of a world unto its own. It's 100,000 different curricula for each physician. But everybody uses CanMeds. Sir?
Thanks. Maybe you can just elaborate for us a little bit about how postgraduate training is protected and funded in Canada.
Sure.
And one of the challenges here is that our training is in fully funded service posts.
Yeah.
The service exceeds people's ability to go away from that. And in fact, the doctors feel they shouldn't study because they're patients to be seen.
Yeah.
And so when you describe competencies that are sequential, year one you achieve this, year two you achieve that, that's almost impossible when the service overlaps with it. So how does it work in Canada? Is it, obviously it's different to resources, but how would you think about applying that here?
Okay. Again, a very big question. I'll do my best to introduce you to it. So Canada does have its own configuration of these issues, but every country I've ever been to tackles this in some different way. So in Australia, there's well-funded posts at various stages, but all of the teachers are unfunded. All of the teachers are volunteer when you get into postgraduate. Only at the undergraduate level will you have a few professors who are funded, for example. The Canadian scenario is that in the undergraduate domain, the professors will often have some sort of stipend from a medical school, funding funneled through an educational ministry. It's not a huge amount, but it'll be enough to incentivize people to more readily volunteer their time. So they'll get a little stipend per hour for teaching. In the postgraduate domain, there's generally no funding for the teacher's role. However, academic departments all tend to pool their billings for fee-for-service seeing patients and use that pooled billing for an academic program. Often they'll hire administrative staff and so on that keep the registrar program running. The registrar is paid out of a Ministry of Health contract, which is negotiated region by region by a union of the house staff. And in that, they've built provisions over time protecting their time for educational components. I think still though, the single most powerful lever to try and have some protected time for for education, has been the accreditation process. So the accreditation standards that come out of our group at the Royal College have evolved over time, but increasingly they say that thou shalt have protected time for an educational program. We try not to be too prescriptive so every site can do it differently, but you must have a protected component, otherwise you can't have a program, which means you can't have registrars, which means you get to be up at night on call every day. So we tend to have motivated people somehow. I'm being a bit cheeky, but in the end, the service gets done. Trainees have to organize their week, and we have to make schedules that integrate and keep the service flowing. The attending physicians are quite present in Canadian hospitals. That's very different than other jurisdictions I've been. So when I go to Australia, my Australian colleagues, it's 5 o'clock, they tend to go home. In almost every discipline, with a few exceptions. And that's evolving over time. But in Canada, we almost have a shift schedule for every discipline with the attendings on shifts too. And that's continued on for into our careers. It's a very different scenario. It's evolved over 20 years. Sir?
Do you have views on, thank you, on the potential of candidates? It's relevant to us in our environment. Often we have people that come from very different educational backgrounds. Mm-hmm. And things like curiosity, insight, engagement, determination, which we expect would reflect the potential of candidates into the future. Do you have any perspectives on that from the CanMed point of view?
So I'll be sorry to tell you that selection and admissions is not my area of expertise. I have colleagues that think about this a lot that would give you a great answer. I will tell you that most of the Canadian undergraduate medical schools use some version of CanMeds in their selection criteria. Some of them more explicitly, they'll actually call it CanMeds. Others will have marking and scoring that reflect some of the domains. I have not yet seen many papers that come out using that framework, but I know that they're using them. I know that they have data on them. And there are a number of trends in Canada in terms of how people select trainees. It's very competitive. I'm not sure what the scenario or the numbers are here, but in Canada for a given cohort of, say it's about 4,000 intake for the country, there would be probably 5 times as many people applying. And the same number of Canadians training in Canada are training abroad in other medical schools because they didn't get into Canadian training. So it's competitive, so it allows you to make selection. How people are using it is in a variety of ways.
Thank you very much. I would be interested in your experience around using this framework in interprofessional education, please.
So again, my mea culpa is I'm not an expert in interprofessional. I turn to Stefanos here for that. But definitely the CanMEDS framework has been used in a number of interprofessional curricula because it's a framework that applies to a number of health professions and it allows you to make intersections and then design curricula for the goals. My colleague Ivy Oanis in Canada has been heavily involved in that kind of work. And they actually wrote a interprofessional framework for the government of Canada for the health professions, of which CanMEDS is kind of woven in underneath the surface. You can see it there. So the answer is, again, it's used in a variety of ways. Yes.
So first of all, I applaud your efforts to move this forward, and thank you. I thank you for the wonderful talk. And you know, coming from the United States, of course, you know, we have these platforms, of course, and the question is, you talked about the e-portfolio.
Yeah.
That is a massive undertaking when we think about that continuum from start all the way through one's career. Do you have any ideas or notions how to keep the technological piece sustainable? Because we know that there are so many dynamic, ever-changing, innovative strategies for technology. Might you have some insight for us to consider should we
Sure.
go
Yep.
forward?
We have a giant
Thank you.
e-portfolio project. It's a multi-million-dollar project. And it's no short of ambition, that's for sure. Even in the Canadian setting, there are hundreds of e-portfolios and e-logbooks. Literally hundreds. Almost every site has dozens that they've all invented. Sometimes it's the registrar that's invented them. They're more tech savvy than the tech people. None of them are perfect. None of them are a killer app. And our group's ambition is to make a killer app that will actually serve people all the way through their career. In Canada, it's actually possible to achieve this vision because we're small. We have, our medical community is such that we only have 17 medical schools. There's only so many doctors, there's only so many sites that people are trained at. And so finding a uniting technology that all of us could contribute to and align with is actually possible. Now, what day we'll pull that off, I'm not sure. We have a version of our e-portfolio that's live. It's very basic, but it's working for our few pilots that we're using right now. Our aspirations exceed the technology right now. So we have a great partner that company has a lot of experience working in the health professions. It's actually an American company called CE City. And I feel confident that we'll pull this off. I'm just not sure what year.
Thank you.
Any other comments or questions? Is there anything that you disagree with that you heard today? Because I'd love to hear your rationale. Anything you thought, oh, there's no way I could do that in our environment?
Thank you. I read a brief article recently by a Harvard professor from the business school who sort of defined leadership and management in a way that I thought was quite helpful, talking about the complementary attributes of each and just saying that a manager maintains stability, a leader pushes for change. So my comment would be that don't you need both in the new framework?
Yeah, thank you for that comment. I think so personally. The group that rewrote that domain of competence is pushing hard for us to change the domain to leader, to make an emphasis, but both components are clearly there. They clearly are sets of competencies for both, for physicians. If you look at the polling we've done with our stakeholders, it's a bit of a split. It's 60-40 in favor of the change. And I almost wonder if it shouldn't be more like the Stellenbosch framework, which is leader and manager. And I would endorse your concept.
Hi Jason, I'm Mariki de Villiers, I'm the Deputy Dean for Education.
Hi, I heard about you this morning. I saw your picture. It's nice to see you.
Apologies, I came from Johannesburg just now. You're quite familiar with our process in our faculty. And in our country, we have a strong emphasis on interprofessional. Some people spoke to that about it. Some of Stefanus's grey hair is really trying to let's all sit together and define our competencies together. And some of the challenges that some of our colleagues have had is that they, in terms of their regulatory authorities, which we call the Health Professions Council of South Africa, say for instance the Occupational Therapy Board or the Physiotherapy Board, they have very well-defined areas and hours that needs to be done. My colleagues must correct me.
Yeah.
So what they then often say is, one of the other colleagues also say is that, how do you add this on? Now, surely your answer should be, it's not an add on, it's an integration, but I want you to give us what is the magic bullet for integration? That's what the colleague in emergency medicine also said. How do we go to people and say that this is already perhaps there? It's not an add one, it should be integrated. So please, your wisdom.
Yeah, I'm not sure I have the magic bullet for that, except to say what I think all of us would agree is that we'll achieve our aims in interprofessional education when we achieve our aims in interprofessional practice. Right? So if the environment reflects the competencies, they'll be acquired. We'll all demonstrate our commitment to them in the way we work. And I think that's true of every jurisdiction. The IPE part does run into some regulations. For example, every licensing authority in the world certifies an individual. They don't certify the team. But we know that you can put a bunch of really very strong individuals, put them in a team, and the team don't necessarily function in a strong way. We know that's true. There's skills around functioning in an effective healthcare team. And so my pithy answer is, when we get that right in practice and role model it, it'll just be part of everyday work. But we have a long way to go.
My question is about the ideology behind trying to define competencies. This was a framework that was developed in Canada from a Western perspective, and I see it's been adopted across the world.
Yeah.
Is that something that's being questioned, that there's a certain assumption that this is what a doctor is, and from eternity this is how it was meant to be and how it should continue? Or is there also questioning about adapting this to different communities? And I think it probably links also to who are the constituents that makes up those focus groups.
Right.
And should we perhaps think about the political implications of trying to define competencies?
Yeah, absolutely. I agree with all of that sentiment. So you'll actually find in the literature some of the debate around any competency framework, let alone this one. This one happens to be a popular one. So if you look at the journal Advances in Health Science Education, you'll see a series of papers rejecting the construct of competencies. It's almost an imperialistic way of thinking. So someone did a Foucaultian, I can't say it right, Foucaultian analysis of competency frameworks that had that conclusion. And again, we use focus groups which are very diverse, but I'll spare you the details. That's still from one country and in one jurisdiction. Does it really apply? You heard me say earlier, it's just a generic framework. No one's selling it. People are pulling it in and making it their own. So anybody that I speak to about CAMEDS, I encourage them to tailor it. Otherwise, it'll fail. It has to be suitable to serve your patients. Make the best practitioners you can to serve the patients that you have in your context. If it's not tailored to context, then it's really a foreign introduction. It has been integrated in a number of different jurisdictions: China, Saudi Arabia. There's a research project in Saudi Arabia where they repeated some of these surveys with the public, and they developed their framework called Saudi Meds. It's published, you can find it. And it looks just like CAMEDS. So there's something about the archetypes in here somehow.
Maybe if I can add to that, Jason. I'm the current chair of the Undergraduate Education and Training Committee of the Medical and Dental Professions Board. And we've gone through an extensive exercise involving all the medical schools in the country, where we have actually adapted the framework for what we believe to be the South African context, with the emphasis on our own context. And it's being used by all the medical schools at the moment to tailor it to their own specific programs. So it can be done, and I'm glad the Saudis call it the Saudi Meds, because there has been noises here that we should call ours the Afri Meds. But I see it being used in other parts of Africa as well.
So an example of that is there's more emphasis for spirituality in the communicator domain than there is in the Canadian version, and that's appropriate.
I just want to ask you, I mean, you've been involved with this for a very long time, and to have it, after having defined all the competencies and what needs to happen, and when it gets to the implementation now and the change management of making it happen, what has been your key lessons learned in doing it or implementing it?
I didn't pay you $5 to say that. There's a workshop after this about change management. Change management is my everyday work. That's what I do mostly, as well as contribute to this educational program. And there are lots of levers and barriers to making the change. If you come to Canada, or if you talk to a Canadian colleague, it will vary what they say about CanMeds. It depends on their setting. So we've been really successful at these medical schools, but the further you go out, the less knowledge there is of CanMeds, or at least less use of the common jargon. They'd still do it, but they would call it that, for example. I'll give you a couple of just anecdotes about successes. An example is we're involved in faculty development on a national scale. We never used to be. The medical schools used to tell us not to come and do workshops at their site because it was their med school, you were stepping on their toes. Now, 20 years later, they call me every week. They want another workshop by our expert facilitators. We developed that cadre of clinician educators. We weren't in that business before. We had a publishing arm for all these resources, and now we have a digital publishing arm for all of these online things we're creating. We never did that before. So each time that we move to the next level, we develop a strategy, communications, faculty development, products, and so on to support the change. We really feel like it's our obligation to support the change. We can't just write standards from an ivory tower.
If you, thanks Jason, if you have carte blanche and you have to introduce a competency-based curriculum, in the ideal world, what will your 2-minute version be? What you do? What do you do? How do you go about doing it?
How would I go about doing that? For what level, Stefan? For what profession?
For undergraduate, let's make it undergraduate medicine.
Yeah, maybe the 2-minute version is, actually I would choose the current reality. As messy as it is, it's the one that serves patients. And if I had my 2 cents, I would advise people to start from scratch, to have the courage to relook at everything you do and make sure it maps to your agreed upon competency framework. So many times, medical schools especially, are locked into allocating time based on departments and so on, traditional structures. And in a competency-based world, if you map out what your graduate needs to be able to do, you should be able to have a fresh conversation about how they'll acquire that competency. And it may not be 4 weeks on internal medicine and 12 weeks here and 8 weeks there. It might be, but we need to have the courage to have that conversation and say, where is the best place to send my student to acquire that competence? And then involves some commitment to assessing in the most pragmatic way the things that we really value. It may not be every little line in the competency framework. It might be the big items. But we need to be committed to assessing every domain and not allowing someone to progress if they can't demonstrate minimum competence in every domain that we all agree is important. That's where I would start.
During your presentation, you referred to each of the disciplines having a slightly different version of the CanMeds.
Yeah.
I just wanted to know if that is available on the website so that one could actually peruse the various disciplines.
Yeah.
The process that we've gone through in the faculty is to try and align and have everyone's input, but it would be interesting, especially if we want to get our house boards on board, to have a look at that as well.
Sure. So the organization I work for oversees medicine. For the other other professions, you'd have to go to each of those different sites to find them. But on our Royal College website, it's a bit Byzantine. You got to click 12 times. But there's a site that has all of the standards documents, of which there's a set of standards that adapts CanMeds to every medical discipline, so surgery, psychiatry, whatever. If you want to find the physio version, the OT version, and so on, you need to go to those individual sites. So it just so happens that this year, every single one of those health professions is revising their standards. And they're doing it, and it's just, I don't know what's in the air, but we're all doing it. And so there'll be a new document produced within 12 months for physio in particular. They're actually in the lead. I'll leave my card. If you want to email me, I'll connect you to that person, and I'll save you some time.
That's something you didn't mention, was the fact that there are various levels to the CANMEDS framework.
Yeah.
And I think that is fantastic in the sense that you have your generic framework up to about level 4, I think. And then as you go down or deeper, you can make it even teaching session specific.
Yeah,
so,
exactly.
Yeah.
That's exactly right.
So the generic framework can really be made profession specific and program specific. Stefan, I just wonder at this point, if you don't want to, also for the sake of people that might not know, just give us a brief overview of where we're standing at the moment at our faculty with the CANMEDS process.
This is I think it's now a 3-4 year work in progress. We started off with a working group in 2010 discussing core competencies and what should that be. It started off with the aim at looking at interprofessional collaborative practice. We worked on that for 18 months with reps from various disciplines. And towards the end, we were nearly finished with the process. I think it was Elise who walked in and said, "Have you ever heard about CANMEDS?" We all sort of puzzled, no. And we compared the two, and it was basically the same, except that the Canadians have better English and grammar than us. So we've changed a few of things to, at least they've refined it for 20 years. We've then divided up into the different roles with each program, each profession with the faculty was represented at looking at the different roles. And we then piloted or started to introduce these competencies in specific areas. People who were willing to say, okay, I'm willing to give it a chance, to pilot it, to see how can we do it. Because obviously change management, you don't want to dump this as something extra. So that was, we're still busy with that. We've introduced that in medicine, specifically in the family medicine, the rehab, community health spiral from first year to final year, and in some other spots where people are willing to give it a try and where it was obvious, we were able to find obvious matches for specific roles. Currently, we're, in a sense, especially now since the Health Professions Council also sort of endorsed this and it becomes part of our accreditation, we're, in a sense, starting afresh, and I think that's why we are so glad that Jason can be here. We've done our homework, we've done our research, we have a few pilots, we understand our context. So we are in a process of re-establishing a core team of people who would like to partner to work on this. As a centre, we've partnered also with the Department of Industrial Psychology at Stellenbosch. They're helping us a lot, especially when it comes to assessment and competencies. And so that's an invaluable partnership with expertise that we don't necessarily have amongst ourselves, and with a lot of enthusiasm to help us with that. So if there's any one of you who would like to be involved in one or other way, even if it's to try something, to say, I would like to assess this small bit, because I think something that you didn't say, perhaps you can elaborate on that, is not to assess everything everywhere, but it may be that in emergency medicine or in pediatrics, breaking bad news can be one thing that you can take responsibility for. So at this stage we're canvassing again for people to become involved. Tomorrow we have a workshop for those in undergraduate health professions education at UCT who would like to get their hands dirty in trying to work this out. And this afternoon we have a workshop, for those of you interested, in postgraduate education. How do we introduce this in postgraduate education and the whole change management process that's involved in this. Our strategy plan for the faculty at this stage obviously is the whole change management thing. It's developing materials to assist professions that we don't all reinvent the wheel, assessment tools for small specific things, and also to get a bigger research framework so that at least we know if you do research where this fits into the bigger picture and also the national picture. So that's where we are currently.
Thank you, Stefans. One thing you didn't mention, and I think someone alluded to that, we might be doing a lot of these things already, but we're not calling it explicitly this role or this role, this role.
Gap analysis.
So Stefans and his team is also busy with a gap analysis in the medical curriculum at the moment, and they've done the first year where they, for each module, determined which of these competencies are already being learned by the students, which are not, and how can we address the gaps. Yes.
Yes, there we go. Emergency medicine. We already do. Thanks for a great talk. I just wanted to speak about the failure to fail concept, because as an assessor, that's something that, is something that hits home. As part of changing your curriculum, you probably need to change your assessment program the same way so that we can actually assess confidently. And I think that's one of the challenges is, as an assessor, you're often not confident that you are able to measure the competency whether at this point in time or over time. And that's probably what's standing in the way of us actually failing people. How do we manage this, as part of this whole curriculum redevelopment and this assessment?
So you have to change the system. So we get the product of a system we've built. In Canada, and I'm sure it's similar here and around the world, we ask preceptors who are diffuse and out there in the masses. We send all kinds of trainees at various levels. We ask them to make opinions, usually after the fact, sort of 4 weeks later, 8 weeks later, 6 weeks later, to fill out some form which is really detailed and really long list, kind of a laundry list actually. And there's usually some score because the university requires us to make a number. And we set it up, and it's kind of an awkward way. So what human being wouldn't do what most of my colleagues do, which is take their pen down a column that they're comfortable with and write some kind of bland, generic comments. I do this too, so I can say this. Like, you should read more. You dress well, thanks very much. And keep up the good work, right? So, and that is absolutely useless. It helps nobody. Though it may help the university get a score. Unfortunately, universities in many of these sort of regulatory scenarios actually hold back education. I'd like to change the conversation to, I'm sending you 3 trainees. You're going to work on 3 milestones with them. In fact, your group is responsible for those 3 milestones. And here's an instrument that articulates the steps along those milestones of competence in that domain. You can make generalized comments as you wish if you see something that's important, like unprofessionalism or unsafe. But I really want you to focus on getting them through those 3 milestones to this level that's described. And that changes the discourse. And I'll tell the trainees that they're responsible for getting those milestones observed. So they come and find you and negotiate with you an opportunity to directly observe. Now in the emergency medicine scenario, I find it actually pretty easy to do direct observation because usually I'm present in the ED and I'm working with all these trainees. Even if I don't watch them interview a patient, I can still hear them through the curtain while I chart on my own patient. So in our scenario, it's relatively easy. For surgeons, it's relatively easy. They're in the OR with people. They can do all kinds of things. So it's asking them to do direct observation in a totally different way on a concrete set of milestones, not the generic everything in emergency medicine. It changes the dialogue, and I think it works. To start.
Right. Jason, I think we must give you time for your voice to rest a little bit before the
Thank you very
next session. Thank you very much for this very interesting and illuminating talk and the very practical nature of it. I think it's especially relevant to us who are grappling with many of those issues at the moment, and for that we are extremely grateful to have the father of CanMeds with us this afternoon and tomorrow also. Stefans has told me that I must give you something which he has hidden.
Did you say which he has eaten?
Is it this one? There you go.
Thank you very much.
Jason,
Thank you very much. Cheers.
Thank you very much.
card here if you want to get connected to somebody.